Hello, and welcome to the compliance session for the fiscal year 2022-2023 statewide training for the School-Based Access Program. I am Deb, and I am the School-Based Access Program Coordinator. I have been in my position since February of 2020, having been hired right before the pandemic began. The Department of Human Services and the Bureau of Program Integrity strive to ensure that the LEAs have a good understanding of the School-Based Access Program. One of the ways we attempt to accomplish that is by holding the fall trainings. Listed here are the key topics for my presentation: Bureau of Program Integrity Overview, BPI audits and audit process, review of selected direct services, common BPI audit findings, and record retention. Allow me to give you a brief overview of the Bureau of Program Integrity. The Bureau of Program Integrity, or BPI, is part of the Department of Human Services, or DHS. Our major role is to combat fraud, waste, and abuse of medical assistance services. We strive to hold providers, beneficiaries, retailers, and employees accountable for understanding and complying with program requirements. There are many different sections found in BPI. The School-Based Access Program is found in the Division of Provider Review and shares its space with the Pharmacy and Ambulance sections. Our supervisor is Lisa McDowell, and our division director is Keith Ivory. BPI includes medical professionals responsible for preventing, detecting, deterring, and correcting fraud, abuse, and wasteful practices by providers of medical assistance services, including LEAs. Education can be a helpful tool in preventing waste and abuse of Medicaid services. BPI is able to recover improperly paid funds, request self-audits, request corrective action plans, and request participation in internal compliance programs. BPI may also apply administrative sanctions and terminate a provider's agreement or preclude participation in the medical assistance program. If fraud is suspected, we will refer the case to the Medicaid Fraud Control Section, or the MFCS, as well as other federal agencies, licensing agencies such as the Department of State or the Department of Health, and or public safety offices as well. If a case is referred to the MFCS, they have the authority to review original records with or without notice, subpoena additional material, make an arrest, or criminally or civilly prosecute providers. These are brief explanations of the differences between waste, fraud, and abuse. One point that I would like to point out is that in order to prosecute for fraud, it must be proven beyond a reasonable doubt that there was intent. Fraud is intentional. The person or persons know that what they are doing could result in an unauthorized benefit to themselves or some other person or entity. The next topic I would like to discuss is BPI audits and the audit process. Whenever you hear the word audit or record request, I am sure most of you start to think the worst. Please don't think of us as the enemy. We are here to help you. We do not get a bonus for taking back large amounts of money. One of the ways that we look for potential fraud, abuse, or wasteful practices is by conducting audits. In order to conduct an audit, the cost settlement process must be completed. For this reason, our audits are retrospective. There are 4 types of audits that can occur. The first type is the quarterly audit. This is a much smaller review that only encompasses 3 months and is done about 4 times per year. Using the Windows RATstats statistical software, 3 school districts are chosen, then 3 students each are chosen from those 3 districts. The second type of audit would be the yearly audit. Again, the Windows RATSTAT statistical software could be utilized, but another system called the Fraud and Abuse Detection System, or FADS as it is known, could also be utilized to choose the sample of school districts that will be reviewed. This is a very extensive audit that spans a whole year, as the name suggests, and the number of students we request records on could be as high as 10 to 15. We try to complete at least 5 of these audits every year. A third type of audit would be the proactive audit. This audit is done in addition to the quarterly and yearly audits. An entire year could be requested that encompasses all services utilized or just specific services. A specific time period could also be utilized. The proactive audit might concentrate on just a specific area. Since telemedicine is a new area, a proactive audit of telemedicine would be an area for a future review. The fourth and last type of audit is a self-audit. Our goal by providing these trainings is to help you receive the interim payments you deserve and to develop a compliant program so that you keep those interim payments that you worked so hard to obtain. The best way to do that is to encourage the LEAs to perform periodic self-audits. Self-audits are a tool that the LEAs can use to determine if compliance is being met. Some LEAs already do yearly audits, some review every file, and others do random sampling. If you do a sampling and find a repeated error, you should then expand the self-audit to see if it is a systemic problem. It is much easier to correct bad behavior before it becomes a habit. You might find errors that require repayment of funds, but by doing periodic self-audits, you can prevent those errors from continuing for many years and therefore having to repay much more money. Self-audit activities include periodic reviews of service delivery and billing, plus review of regulations and requirements to ensure that services were rendered and billed correctly. There are benefits to performing self-audits as well, such as identifying overpayments, identifying services that you could be billing for but weren't, identifying individuals that might be submitting their time inaccurately, whether it's intentional or intentional. Intentional or not, sorry. No one is standing over your shoulder conducting the review. You can do it at your own pace. Know also that BPI will not seek double damages and will accept repayment of errors without penalty. If you find an error, you should always check with PCG or BPI first to find out if it was a paid claim in order to determine the next course of action. The link to the self-audit checklist is included in the slide. Self-disclosures. If you find those errors did involve a paid claim, it is your ethical duty to return the appropriate medical assistance payments. To do that, you contact BPI and we can guide you through the process. Be aware that if the department conducts an audit and it is discovered that you were aware of the issue but did not return the funds, this could potentially lead to administrative or criminal actions. Record review. The audit process begins once it is determined which LEA is being audited. The record request letter is mailed to the LEA. At least 2 copies of the letter are mailed. One goes to the superintendent. Whoops, did I do that? Sorry. One would go to the superintendent and the other one would go to the access coordinator. Once the record request is mailed, LEAs are given 30 days from the date of the letter is mailed to send their records. When receiving the record request letter, make sure to read the letter carefully. It should tell you who is requesting the records, what to send, and when. It is important to respond to these requests in a timely manner. If you need more time in such to gather the information, you can request an extension. I personally can give a 2-week extension, but if you would require more time beyond that, then my supervisor would need to give the okay, and it should be in writing. If the records are sent via electronic, make sure that you send them with a password or send them secure in order to comply with HIPAA regulations. You can also send the records via paper copy or CD. As a reminder, any correspondence that includes identifying information should be sent via password protected or secure. Once the records are reviewed, if there are no findings, and I have had some, then a no findings letter would be sent out and the case can move to closure. If there are findings and they are minimal, then a preliminary letter would be sent out. If the findings are more substantial, I prefer to call the access coordinator to give them a heads up and to go over any, if not all, of the findings. This lets the LEA prepare for the forthcoming preliminary letter and hopefully puts them at ease a bit. The LEA then has 30 days from the date that the preliminary letter is mailed to respond, either to supply additional information or even just to say that they agree with the findings. While it is not mandatory that the LEA responds to the preliminary letter if they agree with the findings, it just lets me know whether I can expect additional information or not. A final letter is then, if additional information is sent, it is reviewed and then any needed changes are made. A final letter is then mailed out to the LEA and they have 33 days to respond, telling me whether they agree with the findings or that they plan to file an appeal. Once the final letter is sent out, no further extensions can be granted through BPI. After the 33 days, a claim adjustment is completed to recoup the money. Once that is completed and there is no appeal, they also have the opportunity to send a corrective action plan. Once that is all completed, then the case can be closed. Documenting staff credentials. An important area within the school-based access program is credentialing. It is very important that the staff have the correct credentials and that they are valid. For this reason, one of the things that is requested during an audit are staff credentials. This includes licenses and certifications. Ideally, the individual should be the one that provides the copy of the credentials, but just in case they don't, for some reason, I have listed here 2 of the websites that can be used for credential verification. One is the Pennsylvania Licensing System Verification Service, which is found on the Department of State website, and the other is the Pennsylvania Department of Education website for PDE certificate verification. It is the responsibility of the LEA to gather and maintain any and all documents relevant to the credential to services claimed. LEAs must maintain the current credentials, such as licensure and certifications, for every provider on their staff pool list. A suggestion would be to make a folder for each employee and scan the documents into their folder as they are received. Then if they are needed, they can be accessed and a copy made. One thing I would like to point out for the first aid and CPR certifications is to make sure that the certification states both first aid and CPR. In one instance, I was provided with a certification that did not include first aid, it just had CPR on it. Maybe the person took a separate course for the first aid, but if so, then that documentation needs to be included also. Any claims that would be submitted by that person could be denied if they don't have the proper certification. The next topic is an overview of some selected school-based access program services. Oops. Why is it not? There, sorry. This is a list of direct services that are available through the school-based access program. I will be talking specifically about the highlighted services. Nursing services, I'll be focusing on the medication administration portion, and the orientation, mobility, and vision services due to some credentialing changes that have recently occurred. Nursing services. Nursing services would be provided to address the medical needs of the beneficiary. Some common interventions that could be performed include medication administration, tube feedings, blood glucose testing, obtaining vital signs, dressings, and wound care, along with other interventions that would be within their scope of practice. Medication administration. If a student is to receive medication during the school day, it must be administered by a licensed nurse, and there must be a medication or physician's order for the medication. A prescription provides instruction for the pharmacist for dispensing the medication, while a medication or physician's order provides instruction to the nurse for administration of the medication. Medication orders are required for both prescription as well as over-the-counter medications and herbal remedies. There are both federal and state laws that apply to medication administration in the public schools. Each school or district should have a policy in place for these services, and the school nurses should be aware of the protocol. School policies should adhere to these laws and not conflict with them. In order for a nurse to give medications, a doctor's order is needed. This is needed so the nurse knows what medication, what dose or how much, what time, how many times per day it is to be given, and how it is to be given, whether it's given by mouth or injection, etc. It is not acceptable to just have the parent send in the bottle of pills. As far as the med-auth, since that is considered the doctor's order for the recommended services, if the IEP and med-auth state medication administration and as per doctor's order, or medication administration as per prescription on file, then the med-auth is where I would expect to be able to reference the doctor's orders regarding the medications or nursing services that are to be performed. Since these are services that cannot be performed without a physician's order, I am looking for the orders to be included with the med-auth for reference. The form that you see on this page is a sample form that is provided by the Department of Health. Each district should have a similar version of this form for the doctor's orders that I referred to. The information on this form is an example of what should be included with the med-auth so that the physician can review it while reviewing the IEP. This is an example of a nursing services log for a student receiving medication. The medication name and dosage, which are required to be documented, should be documented in this nursing services log and/or the daily progress note section of EasyTrack. Any adverse effects should also be documented. Medication administration is billed by the occurrence, not the 15-minute increments like most of the other services. If the student receives medication one time per day, then it is billed as one occurrence. From an auditing perspective, if I am looking at a nursing log that shows the student receives Focalin 10 milligrams PO or by mouth at 12 p.m. each school day, then I would expect to see the doctor's order included with the med-auth so that I can verify the information. Orientation, mobility, and vision services. A student who is blind or visually impaired would receive these services. Safe orientation and movement within his or her environment would be the goal of these services. Telling time, teaching methods of crossing streets or taking a city bus to a specified destination are just some of the examples of what a certified orientation mobility specialist could teach. Please note that a PDE certificate is no longer an acceptable form of credentials through the School-Based Access Program for orientation, mobility, and vision services. The credentials needed to be a School-Based Access Program provider of orientation, mobility, and vision services are certification by the Academy for Certification of Rehabilitation and Education Specialists, or the National Blindness Professional Certification Board. This is an example of a certificate for a certified orientation and mobility specialist. As you can see, it is expired, but on the next slide, I've included a resource for verifying that the credentials are current for this person. It's as easy as entering the person's name and the state. I just did a little cutting and pasting here to show you how the process works. You would enter the person's name and then their state, hit View Directory, and then it should bring up the person's name if they are certified. This is an example of a certificate for a National Orientation and Mobility Specialist for the National Blindness Professional Certification Board. Listed on this slide are the website links for verification of the orientation, mobility, and vision services staff. At this time, I would like to review some common BPI audit findings that continue to be found during audits. This is not a complete list of findings. Group or individual not specified in the IEP and/or the MEDAUTH. If it is not specified in the IEP or the MEDAUTH whether the service is to be group or individual, then the services will be denied. So it is very important to make sure that it is specified. That is what should be reflected in the IEP and the MEDAUTH. Focusing on the last bullet, if the student requires a combination, please separate each service as shown in the example. Order is for individual but billed as group, or order is for group but billed as individual. I have seen this occur numerous times. Those claims would be denied. The decisions regarding whether the student receives the services either individually or in a group are expected to be based on what is medically necessary for the child, and so therefore are not interchangeable. Those submitting claim data should be careful to avoid a costly mistake. This slide also gives some examples pertaining to group versus individual sessions. To be considered group, 2 or more students must be present. If a student is ordered group therapy, but there is only 1 student present, that session could not be billed as a group session. It would be billed as individual, but if the IEP or MEDAUTH do not have an authorization for individual therapy, then you cannot bill medical assistance. You may reschedule or provide a makeup session, but please be sure to document it as a makeup session. The same would apply for telemedicine. If the IEP and MEDAUTH authorize group therapy and you are providing one-to-one therapy via Zoom because only 1 student was available, then you should not be billing medical assistance for the service if the student does not have an order for individual services. Billing for more units than authorized. Units of service must be equal to or less than the units of service that are authorized on the MEDAUTH. If the MEDAUTH has authorized a service for 30 minutes, but the therapist meets with the student for 45 minutes because they feel that that child would benefit for the extra time, that is certainly okay. But the therapist is unable to bill for those extra minutes. There are no edits in place within the system to stop you from claiming that extra unit. This is one of those instances where a self-audit would be beneficial. MEDAUTH errors. The errors on this slide pertain specifically to the MEDAUTH, which have been found during record reviews. These are very important issues that could lead to the denial of all claims for the particular student if the MEDAUTH is not correct, which could end up being a very costly error. The MEDAUTH was not signed by the doctor before services were billed. Providing services prior to the date the doctor signs the MEDAUTH is considered providing services without a doctor's order, and that is a violation of medical assistance regulations. The MEDAUTH doctor or certified registered nurse signature, licensing information, or the date are not legible. Any entries to the record should be legible. If you can't read them, then chances are the person that would be auditing the record will not be able to read them either. I am using this page as an example. If you take notice, the IEP meeting occurred on October the 4th of 2021, but the doctor did not sign the med-auth until December 17th of 2021. We understand that the physician or certified registered nurse practitioner are not always in the building, so obtaining their signatures in a timely fashion is sometimes not possible. But all claims that would be submitted between October 4th of 2021 and December 16th of 2021 would not be compensable and would be denied if found during an audit. The IEP and med-auth should mirror each other. Ideally, the IEP and med-auth should contain the same wording. In example number 1, the IEP reads physical therapy individual 2 30-minute sessions per week. The med-auth reads physical therapy 30 minutes 2 times per week individual. Example 1, they might not have the same exact wording, but they both mean that the student will receive physical therapy for 30 minutes 2 times per week. Example number 2, the IEP reads speech language therapy group 120 minutes per month. The med-auth reads speech language therapy up to 120 minutes per month group. The example number 2 shows 2 totally different statements. Therefore, any of those claims would be denied. If the service is truly medically needed, then the order should reflect that. Also, when reviewing the IEP and writing those orders onto the med-auth, they should be written exactly as they are written in the IEP. Another finding that I have seen frequently is the use of the words up to. This should be avoided, especially in services such as OT, PT, and speech, to name a few. Those words may be better suited for nursing or PCA services, but their use should be reserved for special circumstances, such as instances when it is difficult to gauge how long a service would be provided. Parental consent is incomplete. The parental consent form is a very important document. The parental consent must be completed before any claims are paid. If the dates of any claims are found to be before the date that the parent signs the consent, the claim or claims will be denied. I have found some consents that are signed and dated, but the line or the box giving permission to bill medical assistance is not marked. That parental consent is not considered complete, and all claims for that student could be denied. It is in your best interest to review these 3 key items at the time the parent is signing the consent. If not, it could turn into a very costly mistake. On this slide, I have just highlighted the 3 key areas to pay close attention to. Missing supervisory signatures. The handbook states that the 7 providers on this list need to have a supervisor sign their logs. If a supervisory signature is not provided, then those services will be denied. Both the provider and the supervisor should be signing their logs. Insufficient documentation. Documentation is key to providing services. In nursing, it was always drilled into our heads. If it wasn't documented, then it wasn't done. In order to document the service proficiently, providers should ensure that they are answering these 5 questions when documenting the service. Why did the student present for service or treatment? What kind of treatment did the student receive? What was observed during the service or treatment? What was the outcome during the service or treatment, and is follow-up needed? The Regulation 55 PA Code 1101.51 and the School-Based Access Program Handbook are essentially considered your billing guidelines. They require that your provider documentation fully discloses the service being provided. If the documentation doesn't support the service, then why is the service medically needed? For instance, if the log just says monitoring the student, how does anyone know what the student was being monitored for? An example could be monitored the student for seizures, none noted. Anyone should be able to pick up the documentation and know what was done, how the student participated, and then also be able to continue to offer the services. Billing for non-health related services. Medical assistance does not pay for non-health related services. I am using nurse or PCA services as an example, but other services could be included as well. The example in this particular slide would qualify as billing for a purely educational service. Not anywhere does it show that the PCA performed any health-related service with or for the student. In fact, it doesn't really tell anything. Also, if you look at the start and the end times, they are all inclusive, so it does not paint a good picture as to why the student needs the PCA with them. It also leads the reviewer to question whether the PCA took a lunch break or other breaks, and if they did, they should not be billing for that time. It is suggested to chart in smaller increments of time and to only document medically necessary services. This slide also focuses on nurses and PCAs, even though it could apply to other services as well. It goes back to answering those 5 questions when documenting that are on the previous slide. Cloning. Without complete clinical documentation that includes a description of what took place during each session or encounter, the individual's progress towards treatment goals and future treatment plans, the appropriateness of the service is unclear. This is what should be seen in documentation that is submitted. An auditor wants to see that the provider is delivering services according to the nature, frequency, and intensity prescribed in the treatment plan. Because those services do not occur the same way every day, the documentation should reflect those daily differences. This is an example of cloning. The PCA basically copied one day's entry from another day's entry. Reading these entries would cause me to ask if the service is truly medically necessary. Plus, it raises another question. If the student is always compliant, why is the PCA even needed? It could also fall under educational charting, since the PCA charted assisting the student with classroom tasks. Another form of cloning would be making copies of the logs that are already filled in and then having the PCA sign them. This is also not acceptable. Provider service log issues. Provider logs are daily progress notes and should only be completed by qualified providers. They are used to provide evidence of the delivery of a covered service, progress toward the goals and objectives, analysis of treatment strategy, and any needed adjustments, plus the continued need for services supporting medical necessity. One thing I would like to point out is that if the access coordinator or whoever is entering the logs into EasyTrack enters them on behalf of, let's say, the PCA, if in the comments section of the log they put "See Daily Log," then if records are requested for an audit, then those original logs would need to be sent with the records. Also, if the log starts out as a paper log, that is not considered an electronic document, and the hard copy original logs must be maintained. Those could also need to be sent if requested during an audit. The logs should provide a complete picture of what the direct service provider did with the student. The logs are required to contain exact start and stop times. Rounding off or rounding up of service minutes is prohibited. Most school-based access program services are based upon a 15-minute billing unit. That means I should expect to see times such as 9:02 to 9:17 and not always 9 o'clock to 9:15. The only exceptions to the 15-minute billing unit would be evaluations, medication administration, and transportation services. Also note that service minutes may accumulate on the date of service if the same service is being provided to the same student. This is an example of a provider service log that would be generated after the log was entered into EasyTrack. This log is a great example of what to send with audit records. You can reach out to PCG for assistance if needed in printing them out. I want to point out the circle and the two arrows. OBO stands for on behalf of. This means that someone other than the provider entered the information into EasyTrack via a paper log. As a reminder, those paper logs should be kept as well, so they could be supplied if requested in the event of an audit. The document shown here is not a service log, it is a report. If you look at the document, you can see that it does not have all the elements that a PCG designed service log does. Most importantly, as pointed out, no start or stop times. The last topic I would like to speak about is record retention. Not retaining all necessary records could turn into a very costly mistake. As stated, LEAs must maintain any and all documentation that is relevant to services claimed. Those records can be scanned into a computer file. Just remember that the original documents must also be kept somewhere that is easily accessible in the event that they are requested. This is a medical assistance regulation. Even though other entities may have different requirements for retaining records, for medical assistance related purposes, records should be retained for at least 4 years from the last date of service. For HIPAA and PDE, it is 6 years, so it could be recommended that the records be kept for at least 6 years to cover all the bases. Check with your district to see what their requirements are beyond those 4 to 6 years. For the student that moves to another school district, it would be wise to make a copy of the student's record so that in the event of an audit, the records would be available. Reminder that if your district would decide to discontinue their participation in the school-based access program, you should still retain your records in the case of an audit, retrospective review, or investigation. A few things to remember. Knowledge is the best line of defense. Keeping up to date with the handbook and taking advantage of training opportunities are just a few of the resources available to you. As stated before, we are here to help. We want to see you receive any and all money that your district is entitled to. We also appreciate your feedback, so if you could take a few moments and complete the survey. Thank you for taking the time to watch my presentation and for your commitment to ensuring that your district is in compliance with the rules and regulations that govern the school-based access program. I know I gave a lot of information, but feel free to reach out with any compliance questions. If I don't know the answer, I will try to find out the answer or direct you to the correct resource to find the answer. Take care.